In this presentation, we're going to take a little bit of a refresher training with the Do Not Resuscitate form, which is also known as the POLST form, or the Physician's Orders for Life-Sustaining Treatment. This presentation will be focused to emergency medical services providers. So in this presentation, we're going to take a look at explaining the POLST paradigm and how patients' wishes are documented in a standardized format. We'll describe how the POLST form builds upon and improves existing advanced directives, and we'll advocate for patients by accurately interpreting the POLST form, its instructions, and taking the appropriate action. The DNR form started in the year 2000 as the original orange DNR form, and it's gone through a number of changes over the years to reach its current status as a nationally recognized POLST form. This is the 6th version and offers patients and providers both more options and more concrete guidance in how they should proceed. In 2000, we had the first Illinois EMS DNR form, which had to be printed on brightly orange paper. And a new order had to be written at each new facility that the patient was at. So if they were at a nursing home, there had to be an order written there. If they were in the hospital, a new order had to be written there. If they were transferred somewhere else, there had to be a separate order written. In 2005, the IDPH Uniform DNR form was created, and it was still printed on the orange paper or pink paper or some kind of brightly colored paper. But the positive thing for EMS was that that single form applied to all facilities. In 2006, there was a little bit of confusion if the form had to be used for every in-hospital DNR order. And the answer to that was no. So as a result, it was renamed the IDPH Uniform Do Not Resuscitate Advanced Directive. In 2013, there were a couple of changes. It used a shortened POLST form, and the title remained the IDPH DNR Advanced Directive. Fast forward now to 2015, we had the creation of the IDPH DNR POLST form. What this form allowed us to be able to do is that other practitioners, other than a physician, an MD, or a DO, were allowed to sign the form. And then in 2016, the last and latest revision is that the words "do not resuscitate" or DNR were removed from the title, and so now all we have is the IDPH POLST form. Also, some care options were redefined and clarified to be able to give medical providers some more guidance. So here we see some images of the old forms. We see the pink version that was released in 2006. We have the original 2000 form, and then we have a copy of the Do Not Resuscitate POLST form that was released in 2015. So here is a copy of the version that is currently in use now. It is what is being issued for patients who are signing these orders today. So this is what we'll be taking a look at and taking a dive into. Now, there is one important thing that I want to emphasize here, is that any version of any of these forms, whether it be the POLST form or the original old yellow form, or whether it's the pink and purple form, all of these forms are still valid. A form is valid until either the patient revokes it, the patient's power of attorney for healthcare revokes it in the absence of the patient being able to do so, although we'll talk a little bit more about that in just a few minutes, or the patient ultimately expires. So there are no expiration dates, quote unquote, on these new POLST forms. They're in effect until either they're revoked An order is also considered to be revoked if the patient completes another form that has a later signature date than the original form. So the one thing that we have to really be careful of with these types of forms, though, especially with this POLST form, is that if staff were to look at a completed form and automatically assume that it indicated that the patient was do not resuscitate, it's actually possible that the patient could be allowed to inappropriately die from cardiac arrest. We really have to take a look at this form, and we're going to go through line by line here, and we're going to see why that's so important. So this slide gives us a general overview of current advanced directives in Illinois. So the one key takeaway here is that we should only rely on advanced directives only if the patient cannot make medical decisions. Now, there are some of these in which EMS can follow, and there are others in which we're really not going to be able to follow. Obviously, the POLST form, that's something that we're going to be able to follow. Power of attorney for healthcare, we may get into. We will take a look at those documents, and if those can be provided and somebody can properly identify themselves as the healthcare power of attorney, then in consultation with medical control, that person does have the right to make certain, but not necessarily every type of decision. If we're really presented with any of these other types of advanced directives, we're definitely going to need to involve medical control, inform them as to what's going on, what the directive says, and then ask how they want us to proceed. In some instances, the patients may have an advanced directive for directions for emergency care. This is something that we would want to take a look at, but we would also need to consult with online medical control to kind of get their guidance as to how they'd like us to proceed. So the POLST initiative is actually a nationwide kind of event as a way to try to standardize do not resuscitate order practices across the country. So this new form was modified with its revisions in 2016 to be able to align with those national standards. And actually, in Illinois, before I misspoke, I called it physician orders for life-sustaining treatment, where in all actuality, it really should be practitioner orders for life-sustaining treatment. And the reason for this is because the practitioners that are authorized to sign this form does include physicians, but it also includes advanced practice nurses, physician's assistants, and medical residents who have completed at least 2 years of their residency. So the intended use of this form is to be discussed with patients for whom death within 1 year is expected. Those with advanced serious illnesses and the frail and the elderly. This form is voluntary, and as such, there was language added in this last revision stressing that the form cannot be required of any patient and is completely voluntary. Some of the benefits of a patient taking the time to complete a POLST form with their medical practitioner is that it provides medical orders that must be followed by healthcare providers if those orders are within that individual's scope of practice. It's an easily recognized and standardized form for the entire state, and the form is intended to go with the patient from care setting to care setting. So when you're picking a patient up at the nursing home, you should have a copy of that form to be able to take it with you to the hospital, and that form should continuously follow that patient through their healthcare journey. I've alluded to this a little bit already, that all older versions of the form that are still in use are okay. A valid form doesn't expire, and it should be honored. Forms should travel with the patient at all times and be readily accessible to healthcare personnel. it should also be noted that copies of any of these forms are acceptable as well. It does not have to be an original copy on a certain colored piece of paper. A black and white copy of these do not resuscitate forms, the POLST form, all of them are valid, and EMS providers should follow them to the best of their ability. So this is also something that we've briefly touched on, but what if two or more different forms are presented? The newest valid form voids past forms. So follow instructions on the form with the most recent date and all of the required elements. However, it is not EMS's job to investigate for the presence of other forms. Consider the form that is presented to you to be the most current. There are 3 primary medical order sections in the new 2016 version of the IDPH POLST form. Those sections include instructions on how to proceed if the patient is pulseless and not breathing. Section B addresses if the patient has a pulse or is breathing. And then Section C is medically administered nutrition. So fortunately for us, Section C is not going to apply to EMS except possibly in the interfacility environment. And there's something that you're going to notice really odd in Section A. And this is what is very, very important that we were talking about before. The patient has the option to select in option A whether to attempt resuscitation or to not attempt resuscitation. So just because there is the presence of one of these forms does not mean that the patient is DNR. So this is going to be the first box that we're going to see. Section A, cardiopulmonary resuscitation. Patient has to have no pulse and not breathing in order for this section to apply. The patient can select attempt resuscitation, CPR, and this is the whole shebang. This is intubation, this is ACLS measures, this is CPR, defibrillation, this is everything. If the patient has selected the do not resuscitate box and the patient has no pulse and is not breathing, advanced level providers, you will verify asystole in 2 leads, and you will contact medical control for death declaration while informing them of the presence of a valid POLST form / do not resuscitate order. The key takeaway here is that if the DNR box is checked, do not begin CPR. So one of the questions that's often raised is, attempting CPR is the default request. Why use the form to request CPR? The elderly and those with certain types of disabilities may fear that they will not receive the same emergency care as others. So they may have created a POLST form marking a DNR box during a serious illness, but they can create a new form if the health improves or they desire to reach a milestone moment. So now they'll select the attempt CPR, attempt full resuscitation, full resuscitative measures. Section B addresses medical interventions, because remember, a do not resuscitate order does not mean do not treat. So we have multiple options here that the patient can select in terms of what actions healthcare providers should take if they are found with a pulse and or they are breathing. So essentially it addresses the extent and to the intensity of the desired care if a patient is in I will call a peri-arrest situation, or those patients that if we don't do anything, they'll end up in full cardiac arrest. So full treatment is the easiest. We want to stabilize them. We'll utilize every tool in our arsenal that is appropriate for our scope of practice and for our protocol. The selective treatment box, the primary goal of treating medical conditions with selected medical measures. So these patients can get comfort-focused treatment, We can use IV fluids, IV medications, and this can include antibiotics and vasopressors such as dopamine for our paramedics, as they're medically appropriate and consistent with patient preference. However, these patients we do not intubate. We will not intubate these patients. We will not place them on a ventilator, things of that nature. We can consider less invasive airway support for these patients, such as CPAP, and transfer to the hospital if indicated. So normally we'll take them to the emergency department. However, the form guidance is largely for hospitals to avoid admitting the patient to an intensive care unit. And then the last box is comfort-focused treatment. So really, we're looking at sole comfort measures here. So relieve pain and suffering through the use of medication by any route as needed, use oxygen, suctioning, manual treatment of airway obstruction such as manual maneuvers, head tilt, chin lifts, jaw thrusts, things of that nature. Do not use any of the treatments that are listed in the full and selective treatments box unless it's consistent with a comfort goal. In these instances, patients should be transferred to the hospital only if comfort needs cannot be met in the current location, whether it be because of scope of practice issues, equipment issues, but ultimately we should try to leave these patients at home in concurrence with medical control if at all possible. Also, there is the possibility for some free texting in terms of optional additional orders. If those orders are within your scope of practice and within your protocols, you can follow those orders. If, however, they are outside your scope of practice or they are outside of a protocol, then online medical control should be contacted and asked for direction on how to proceed. If a patient is found in full cardiac arrest, no pulse and not breathing, the chance of them surviving neurologically intact is less than 50%. For this reason, many patients would likely choose the Do Not Attempt Resuscitation DNR box in Section A. However, the same patient may also believe that if they are choking or having a severe asthma attack and are in need of an inline neb or an advanced airway, that would save their lives and preserve their neurologic function. They may choose this option. In Section B, full treatment is not meant to also apply to cardiac arrest management. So Section B only applies if the patient has a pulse and or is breathing. So if they are in full cardiac arrest, we only look at Section A. If they are not in cardiac arrest, we only look at Section B. An example of utilizing this option here, which is highlighted on the screen of selective treatment, they may want a trial period of CPAP and BiPAP, but they don't want to be intubated. This patient may be far more comfortable if we can provide non-invasive pressure support ventilations and or position them appropriately to relieve their stress. King airways, LMAs, combi tubes are other examples of advanced airways that the patient generally intends to refuse if this box is marked. So for basics and first responders, if we have somebody who has checked this selective treatment box in Section B, then we will probably go ahead and stay away from those blind insertion airway devices. However, that's really a non-issue for us, as our protocol states that those blind insertion airway devices should only be used on patients who are in cardiac arrest. A good example of the comfort-focused treatment that we've talked about would be a patient on hospice. They want to be kept out of pain, but they want to be left to die at home. One of the problems that EMS personnel face is being called to a home because the family does not know what to do when the patient deteriorates and end of life appears imminent. Families panic, they call 911, and EMS responds, and the family requests help, but they do not know what that help should be. EMS usually has to transport the patient even though the patient's wish is not to be transported. There is now a caveat written into the form that states transfer to hospital only if the needs cannot be met in the current location. Meaning that if you can stabilize the patient and you can assist that patient and we can keep them at home, then that is what we should do. Once again, EMS can only provide interventions entered under the additional orders if they are within their scope of practice. If these orders are questionable, contact online medical control for direction. This does not count as one of the check marks. So one of the other 3 boxes have to be checked. So these are in addition. So what might we possibly see in this section? Use of pain medications and antiemetics such as Phenergan or Zofran, but no cardiac medications. We could see limited additional patients, so no defibrillation, no oral, no nasal airways, no IV, or only giving IV fluids for hydration only. So there are a lot of different things that can be written in those order sections. As long as they're within your protocol and within your scope of practice, you can follow those. But if you have any question, contact with online medical control. Section C, EMS providers can usually ignore. This is as a result of the Terry Schiavo case that was in Florida, if any of you are familiar with, which involved a long protracted legal battle involving the removal of a feeding tube. So this is something that typically we don't have to worry about unless we're in that interfacility environment. For patients that do have a tube and that need transport, you can contact medical control if you need direction on how to be able to handle that device. So anyone can witness the POLST form being signed. The only restriction is that the primary caregiver, or the physician, physician's assistant, advanced nurse prac, medical resident, etc., the primary caregiver cannot sign as the primary caregiver and also sign as the witness. So the 2 signatures that we're going to be looking for will either be the patient's healthcare power of attorney, or a healthcare surrogate, in addition to a witness to consent. If consented by the patient's legal representative, supporting documents verifying the agent's powers are not needed by EMS. If it is signed and it's everything appears valid, it is not our job to determine the validity of the POLST form. Rather than if it has been presented, all the required signatures are there, we will take it as valid. We have to have the practitioner, so physicians, name, signature, and an effective date in order to be valid. However, you may see that the practitioner's signature might be written in cursive or print by a nurse, who then adds his or her own initials. This is acceptable, and the form remains valid. So let's recap quickly to make the determinations for the requirements to make a POLST form or DNR form valid. We have to have the patient's name. We have to have resuscitation orders. So Section A has to be completed. There have to be 3 signatures. The patient or the patient's legal representative, a witness, and then the medical practitioner. In addition, we have to have the date. It's important to understand all other information is optional. So Section B may not be filled out at all. Section C may not be filled out at all. Section A is required to be completed. Now, with all that being said, let's say that Section A has been completed and it is marked Do Not Resuscitate. Section B has no markings on it whatsoever. Remember, DNR, it does not mean do not treat. So even if the patient is do not resuscitate, if the patient still has a pulse and is still breathing, we will treat them in accordance with our standing protocols, and this can include ACLS medication, intubation, things of that nature. However, the moment that the patient no longer is breathing and no longer has a pulse, at that point, the do not resuscitate order or the POLST form is in full force and effect, and medical control should be contacted to discontinue resuscitative measures. So who can revoke these orders? Obviously, the patient can at any time. Other situations can be more complicated and can take some time to resolve. If there's any doubt or dispute, contact online medical control for assistance. A power of attorney or a healthcare surrogate should generally not overturn decisions made, documented, and signed by a patient. EMS responders are legally protected if they follow the orders on a valid form in good faith. So, a power of attorney or surrogate could very well argue that a patient who wanted full treatment before has now deteriorated to the point where he or she would only want selective or comfort measures. That change in status can usually be quickly approved by the online medical control physician. However, if a POA or healthcare surrogate wants to overturn a comfort care order and escalate to full treatment, that decision must be carefully reviewed with online medical control. A power of attorney or healthcare surrogate is supposed to act according to the patient's wishes and not their own. So what if a POA or a surrogate disputes a valid POLST order to which they previously consented? So what we have to determine is, let's say that it was the healthcare power of attorney and not the patient who signed the form. If the POA was the person who originally signed the form, they can change the form. If, however, they were not the person who signed either in the patient box or the patient representative box, then we follow the orders on the POLST form and we contact online medical control for further direction. So let's go ahead and take a little bit of a scenario. John Doe is the patient. John Doe has signed a POLST form which indicates that he is do not resuscitate. John's daughter, Jane, is the healthcare power of attorney. John goes into cardiac arrest. EMS is summoned. EMS is provided with a POLST form, which is clearly indicated that John has marked the do not resuscitate box. Jane states that she's the healthcare power of attorney and she wants to basically have the POLST order ignored, and she wants John to be resuscitated. In this instance, EMS should not initiate EMS resuscitative measures. They should follow the orders on the POLST form, and they should contact online medical control for further direction. A lot of people ask, what is my legal risk for following a POLST order? A healthcare professional, EMTs, first responders, intermediates, advanced EMTs, and paramedics are all included, who in good faith complies with a do not resuscitate order made in accordance with this act, is not, as a result of that compliance, subject to any criminal or civil liability except for willful and wanton misconduct, and may not be found to have committed an act of unprofessional conduct. And this comes directly from the Illinois Healthcare Surrogate Act. One of the questions that I frequently get asked in the office on the question of immunity, whether it pertains to do not resuscitate or to just EMS immunity in general, is what exactly is willful and wanton. So there are various legal standards of negligence under the law. There is simple negligence, which is the simplest to prove. In those cases, you have to prove that there was a duty to act. You have to prove that there was a breach of duty. You have to prove that that breach of duty was the proximate cause for causing damages or injuries to a patient. And that's all they have to prove. With willful and wanton, they also have to prove that through your course of action, to show an actual or deliberate intention to harm, and if not intentional, shows an utter indifference to or conscious disregard for a person's own safety and the safety of others. So, English translation from the legalese is that in order to prove willful and wanton misconduct, you essentially had to have done it on purpose and were looking to cause harm to a patient, which is obviously something that none of us as EMS providers would ever do. There is a page 2 to this form which may or may not have any information on it. It lists advanced directives for the patient. It might provide information for their healthcare provider, for their physician. However, this side is purely optional, and EMS personnel do not need to review or take any action based on any of these notations. As EMS providers, we only care about page 1 of the form. However, it's important that we, if we are transporting the patient to a hospital who has a POLST form, to make sure that we have both sides of the form, or both pages if it's been copied that way, so that the hospital has that information should they need it. So, just a kind of a quick recap. Section A, CPR, yes or no? Are we doing CPR or are we not? Section B, if the patient's not in cardiac arrest yet, how aggressively are we going to treat these patients? And then Section C, we can ignore it because it does not concern us. So, an unconscious adult patient in bed at home. The patient is not breathing, but does have a weak pulse. An IDPH POLST form is on the fridge. What part of the form is most relevant right now? Is it A, Section A? Is it B, Section B? Or C, Section C? The answer to the question is B, Section B. Because the patient still has a pulse, Section A does not yet apply. Also, Section C discusses the placement of feeding tubes and is not immediately relevant here, or really at all to the EMS environment, as the placement of feeding tubes is outside the scope of practice of even the highest pre-hospital care professional. I've already stated that originals are not necessary. A healthcare worker may presume, in the absence of knowledge to the contrary, that a POLST form with all the mandatory elements noted or a copy of that form is valid. However, it is recommended that the form be printed on pink paper to make it easier to use and easier to find during times of crisis. But it does not have to be printed on the pink paper. A completely executed form is valid regardless of the color, and photocopies are acceptable. So to sum it up here, EMS personnel must follow a valid IDPH POLST order relative to resuscitation attempts in cardiac arrest situations. A valid POLST order should be honored relative to the extent of care if patient has a pulse or is breathing, unless compelling circumstances cause online medical control to direct EMS personnel to provide alternate care. It is my hope that this presentation has helped clear up some misconceptions or some concerns related to do not resuscitate orders and POLST forms. However, if there are any questions or further follow-up information is needed, please feel free to contact me in the EMS office. at 309-827-4348 or contact me via email at dferguson@mcleancounty.ems.org. Thank you for watching, and stay safe out there.